Okay. Having heard all of these inputs, I will elaborate on what kind of a scale we can make and program and how we can use that scale.
Şimdi aslında
As a matter of fact, when we are interviewing, we always cling to the questions, am I missing something? Have I forgotten any question? As psychiatrists, time really matters. And it might be a bit challenging to ask about all the domains. And sometimes the problem is the patient intentionally hides some of the stuff and later on adds, maybe in the fourth interview, okay, after many of the things he says all of a sudden, I know I have taken it away from you, but this actually happened that way. This is quite common in our practice, and this is something that we've been elaborating a lot upon, whether we can resolve the problem, particularly for our younger colleagues. It's really important, and for psychologists, it's an important matter. Therefore, to have a thorough assessment of mental health, it is our fundamental goal to have a standardized scale, but the scale must be comprehensive. As we have seen in the previous presentation, we have limited access to many areas. Should assist a clinician. I mean, the scale should intend to assist clinical practice of the clinician. It should be of hand, to clinicians. And the third point is, particularly for the diagnostic scales, the problem is the scale makes a clear-cut diagnosis, and you should be following it, adhering to it. And whatever that diagnosis of the scale would be, you should be one-to-one adhering to the scale diagnosis. But this is not how the clinical practice works, as you know. And the scale should indeed help us, and we should be left more liberal in our diagnosis. Therefore, I most of the time look at the scale and say, okay, the scale ends up in a certain conclusion, but I can use it in a way that the information is given. So we need something that would not be definitive in terms of clinician's decision, but would help, rather, the clinician to make a decision. Not only the mental health issues, but also other areas, like, for instance, if one person is presenting with depression, is not leaving home, really it's important for us to discover the presence of depression. But we should again see what kind of a behavior there is in not leaving the home limits, so we can change that behavior. It should also be sensitive for monitorization, because we need to see what kind of a change we have achieved, and the practice should be lasting short. These are contradicting issues, and as we have seen quite clearly at the end, one of the important criteria is to have a brief scale, because the longer it is, the chances for mistake would be higher. Therefore, it is important to have a brief scale. And at the end of the day, the target is not to make a diagnosis, but rather to identify the risk, because to make a diagnosis, you need maybe 3 times more of a question list. But if you say the aim is to identify the risk, it would give more space to the clinician, and making a diagnosis is really ambitious as a target, and everything it takes for you to make that diagnosis would be more challenging. Therefore, we rather aim at identifying the risks. So at the end of the day, we need something to make a multi-tier assessment and to shorten the time of filling in the form. There are skips. If you're asking the questions, the screening question, there is a part about the screening questions. We ask the question, if there is nothing there, we skip it. But if there is a possibility, in the first part, we must just fill in according to the needs, and then there will be a flip down part. So we're saving from time. and they will be talking, the later speakers will be talking about the details, but it's quite, applicable time. And we have to finish in a time that the patient will be more concentrated in answering your questions. Multi-tiered means, of course, biopsychosocial model should be used, and this is something that we all know. Biopsychosocial model is something that we keep talking about, and in a very short period of time, biopsychosocial model assessment wouldn't be that possible. And the biggest difference of psychiatry is that it's a multidisciplinary field, and it requires a multidisciplinary approach. We need to have a level assessment of the individual. Biopsychosocial model is the one that would fit the most to this target, but mostly we are focusing on the biological or the psychological aspects, and then the treatment is decided upon accordingly. Therefore, in psychiatry, a multi-level assessment is extremely important. That would give a favorable outcome for the clinicians. Multi-access assessment is really teaching a schematic data provider. Therefore, as a matter of fact, there are many advantages of multi-axial assessment. And of course, we want to see the advantages accordingly. And the first tier, there are the mental problems, and the personality features, psychosocial functions, and environmental factors, functionality, general physical situation. This actually would be provided to diagnose according to these axes. What does it give us? There is a similar aspect, a similar part in the older version of DSM. It provides an integrated approach, an integrated assessment. A holistic assessment should be given to the patients, but how? Therefore, multi-level assessment in psychiatry means a holistic assessment of the patient at the same time. Therefore, multi-axial assessment or multi-level assessment is quite an important priority. For that reason, RITA, this is the Mental Problems Risk Screening Questionnaire, RITA in Turkish as the abbreviated name. RITA aims at screening the risk, as you can see, because the aim is not to make a diagnosis, but rather to give some helpful data to the clinician. It is intended for the individuals about the age of 18. We're now working for the group under 18. The most important characteristic of RITA is that it gives information whether or not there is different level of information provided. Moodist is really a very good place to run these studies because it has many patients of this kind. By the way, it's computerized. What does it cover? In mental health issues, I forget about the number all the time, but there are 21 different domains it covers. Some addressed with shorter questions, some with longer, and also characteristic features and psychiatric robustness is important. Behavioral features, impulsivity is important, relations. For depression and for anxiety disorder, it's an important data provider. And for psychosis, social support is important. Lifestyle is important in all mental domains. Family history, it's a very long history taking, but I will show you it's facilitated here, and assessment of physical problems. Okay, this is the question map of RITA. In the first column, you can see the field or the domain questioned, total number of questions. And the third block, let's take a look at sleep. I mean, there are 10 questions. If one question is answered yes, then there will be a mental trauma part opened up, which means we will ask 15 more questions. But we can get brief questions. Mental problems in the family are questioned with 2 questions. And this also, will trigger another 2 questions.
Peki nasıl uyguluyoruz?
How to apply?
Uygulanıyor. Uygulanacak herhalde. Çünkü
RITA is going to be started within a week, so the system will be in application in a week. We've been running the test drive for about 6 months. Every time there is a problem that comes up. How to apply? First, the interviewer asks how to fill the form. How would you like to fill in the form? We can send in an SMS, a link on email or WhatsApp. And clicking on the link, the questionnaire will pop up on the iPad or the mobile phone. Or it can be, if there is no mental insufficiency problem, then we can start asking the questions at the clinic. This is the main screen. On the main screen, to the left side, you can see mental problems. On the right side, functionality, comparative level of violence, personality features, comorbid factors, and diagnostic criteria. By the way, we ask the person how he or she is feeling. If he or she feels really bad, then there might be a need for an emergency. Comparative violence level is intended for listing down all the diagnostic criteria in order. This is the list of all the mental problems, and you can see the risk level. And this way, for instance, you may think, this is not a bipolar case, so the test is not relevant, but obsessive compulsive disorder is quite prominent, and maybe for the rest of the items we can work further. It will give the psychiatrist a chance to make an interpretation. Functionality disorder considered in 4 domains. You can see personality traits visually will be presented. You can see the factors, all factors about the person. This is an invented person. I'm just for the purpose of the presentation. Social status, high education level, single, no economic problem, has a regular job, behavioral features. There is the risk for impulsivity. Also, there are problems about anger management, for instance. Diagnostic criteria. For the ease to the clinician, sometimes we cannot remember diagnostic criteria, but we've included them here. And as you can see, phobic anxiety, if it's clicked, then you will see all the diagnostic criteria. And this way, there is no need for an extra source. Impacting factors. By the way, you can see a summary of all the domains. But if you want to have a more visual display, you can click on each domain. I am a visual person, and I don't want to be drowned in texts. I need to read it several times. But visuality really is important to me. The best books are schematic books for me, for instance. I really love those books with drawing schemes. So for the ease of understanding, and the target is to assist the clinicians, not to make her or his job more difficult. If you click on social risks level, actually here on the lower panel, we indicate the status, the economic status, but we also indicate whether there is any problem about a level of education or the professional status. So it's better visualized. You can see some behavioral traits are included here. For behavioral aspects, impulsivity, lack of anger management, and excitement inquiry. You can see excitement inquiry is quite high here.
üst düzeydesiniz de işte bu
And
bize
if you come on it, then you can also visualize the level of violence, all scored between 0 to 2. So it's a standard image.
içinde 0 ile 2 arasında bir puanı var.
Every scale has a score between 0 to 2. Family history, as you can see, first and second level relatives, depression in mother, and attempted suicide in a close relative indicated. Well, you don't need to ask for all other relatives, and the system already asks for you. Physical problems, 3 or 4 questions are present. Mostly, you can see the graph as in here. Physical problems of the individual impact the quality of life to a certain percentage. We can here speak about a concrete physical problem. Relational problems, maternal, paternal relations missing, partner relations, and child relations, the 4 domains questioned. To the side, you can see the total score of the relations, and in terms of the level of relations, paternal relation is worse. This is one of the tests, so there is a missing part. Partner and child relations must be assessed here. This is really important if you see an older patient. Relations with the children is to be questioned. Sometimes we cannot have a thorough understanding of that in the first interview, and it's also something bad to overlook it. Therefore, it would help you probably if you would be aware of it initially. Lack of social support, problems of lifestyle. This is really an important domain because in most of the mental diseases, this is one of the things we can change, lifestyle. It would help a lot to make sports and to socialize. We know that sports is treating, it's therapeutic in many instances. And as the graph increases, the gravity of the problems also tend to be higher. If you want to see everything in a single page, the system will give you a report page, and the clinician may have it printed out as well, because sometimes and in some places a writing and printed material is asked for the file. So there is the chances of having a hard copy of that. You can also just match it with the answers page. And this page also is printable. The answers to every question will be given here because you would be curious about the answers to questions. In computerized programs, there are generally reports. For instance, the risk of committing suicide is indicated, but also the suicidability comes with a high score, not purely because of suicide questions, but from the depression score as well. It's not only the score of the system, but your own appreciation is important for the patient as well. Patients like this kind of stuff. Therefore, on the right corner, there is a printout button. This is a patient's report screen, and the patients want to have something. They want to keep something at hand. Giving feedback is an important factor for the treatment of the disease. So it's also possible for the patient to take a printout. And you can also transfer data to Excel program. And you can also keep on going that way. You can take notes, upload photographs of the notes you're taking with your own handwriting, because this is something that would accelerate the way you're functioning. And again, on the left side, you can again click on your notes. This is a tracing screen. The tracing data will come in a month. After all the data you enter in a month, you can just track the patient. For example, in this patient, there was no depression previously. Now there is depression. Anxiety was high, but now it's even higher. Since we have invented data, the data would come higher than usual. Yeah, I mean, it's a busy table, but especially for tracing the mental diseases, it would help us very much. But personality traits are not present on this screen because we assume that they would not change. Well, in the end, it's a comprehensive but user-friendly scale. Visual presentations facilitate appreciation. It's valid, applicable, and also the interviewee can see the summary results. It would facilitate the way we're working. Clinician may keep and take private notes. It's possible to track the patient and to detect any change, if any. So we can also see the form reliability. Neslihan will be covering the other parts of the form. But this website is where you can find also a version. I mean, it's not available yet. We don't know whether or not it would be paid. I mean, it's also have developed, but the rest of the team will decide for the chargeability of the system. And I am going to end my words here, and Anil will take the floor to speak about the rest of the system.